Hi, my name is Michael Brandis with Bingham Healthcare's marketing department, and I'd like to welcome everyone who has joined us today for our Bingham Healthcare Be Informed webinar series that we're just beginning. Thank you for joining us, and we are excited to bring you our first Be Informed with Bingham webinar. With the current situation over the last couple of months, we have had to suspend all of our in-person events. However, we understand that your health is essential and you may still have questions, which is why we wanted to bring you these webinars so that you can hear from our providers and learn more about their specialties. As a reminder, this will be recorded live, so please keep in mind as we have our conversation today, also considering we will be sticking to a certain time frame today so that our doctor can get back to seeing patients. So we will try to answer as many questions as we can. With that being said, I would like to welcome Dr. Nicholas Pearson, who is an orthopedic surgeon with Bingham Healthcare, and he specializes in sports medicine as well. Dr. Pearson, thank you for being with us today.
Well, I appreciate you guys having me here.
How are you doing?
I'm doing good.
That's good. So first of all, what is it that you enjoy about being in Eastern Idaho?
So I grew up here. I did high school at Blackfoot High School, and you know what really made me want to come back was just the outdoors. I love being outdoors. I love camping, hiking, fishing, and hunting, and I wanted my kids to experience that as well.
That's fantastic. And then a little bit further, what is it that actually inspired you to become an orthopedic surgeon?
So actually, when I was going through my undergraduate time at BYU, Idaho, actually, and before that, when I was in high school, I did a lot of construction work and actually was a framer. And, you know, it's kind of interesting, but there's a lot of correlation between framing a house and taking care of the human body. And in fact, you know, I jokingly with my wife a lot, I talk about how similar a lot of the instruments are that we used in framing houses. And when I first came into contact with orthopedics, I noticed that I got to use my hands and I got to see the work that I was doing in a similar manner that we did with construction. And so I think that's what drove me to orthopedics is, you know, it's very satisfying when I'm able to help a patient that comes to me in pain and is, you know, having less quality of life at that point, and to be able to see them transformed into somebody that's able to get back to what they love doing. So that's why I chose orthopedics.
Wow, well, that's really interesting. Thank you for sharing that with us. So what I'm going to do is break this up into two segments. What I'm going to have you do is talk about what you specialize in from the shoulders down to the knees, and then let you talk about that, and I'll have some questions for you regarding those areas.
Okay.
And then what we do is because this has been on Facebook, we actually have a number of visitors that have actually asked questions, and I'll be asking you those from our viewers, and then you can answer those, and we'll kind of go from there. Does that sound okay?
Yeah, that sounds perfect.
Okay, great. So the first thing is, you specialize in hip surgeries, knee surgeries, and shoulder surgeries, and procedures that are related to each of those areas of the body.
That is correct.
What is it? First of all, who would be the right candidate for those types of surgeries?
Well, so I think we need to break down the different types of surgery. So like you said, I do specialize in the shoulders, hips, and knees. And there's a lot of different types of procedures. You know, sometimes people get a misnomer because they look on the website and they see that my specialty is orthopedic sports medicine. And a lot of people say, okay, well, because I'm not in sports or maybe I'm more elderly, that I wouldn't qualify to go see someone like this. And really with my training, you know, I treat people from young adolescents all the way up to the elderly. And everyone can benefit from these more minimally invasive techniques that we utilize. So breaking it down, starting with the shoulder, you know, there are a lot of different types of procedures that I do, such as arthroscopic procedures. So when I say arthroscopic, I mean that I'm going in with a camera and small little poke hole incisions in order to fix whatever ailment, injury may have occurred in the shoulder. So such as like a rotator cuff tear, a labral tear, things like that. And so that can come in all, ages. Typically, we see rotator cuff tears anywhere from people in their 40s to people late into their, 70s, 80s, and 90s. And so, a rotator cuff tear can be treated through the scope in a minimally invasive fashion. Now, the other types of shoulder surgeries that we do are shoulder surgeries that are an open procedure, which would entail like a total shoulder, a reverse total shoulder. And these are for patients that have potentially arthritis in the shoulder. And so again, understanding what arthritis is the degradation or the degeneration of cartilage that occurs in that joint. So if you really think about it, the joint space is created by cartilage, and as that joint space gets worn out, that gets narrower and narrower. And so eventually you could be left with bone touching bone, which could be very painful. And in that case, really the procedure is to replace the shoulder. And then there's some technical nuances that if somebody has a rotator cuff tear and arthritis, then they may be a candidate for what's called a reverse total shoulder arthroplasty. So, like I said, there's a whole host of different operations that are potential, in the shoulder, and we can help with those. For people that have had shoulder dislocations, there's procedures to stabilize the shoulder, and again, we've talked about the rotator cuff tears. We've talked about, people that have labral tears. There's procedures to help fix that labrum. Sometimes people have pain in the upper biceps, and we can take care of that as well. And so, for people that feel that they are feeling a lot of grinding and crepitus, that may be that you have some arthritis in the shoulder, and we would need to take some x-rays and images to see where you're at with your injury and disease process in the shoulder. So that would take care of the shoulder. Then we go to the hips, and in my training, and I don't know if you care if I segue to here, but I was trained in Michigan, affiliated with the University of Michigan, and that's where I did my what's called my residency program, and that's 5 years of orthopedic training there, and it's more based on general orthopedic training. So we did total knees, total hips, total shoulders. We did scopes in all of the different joints. But one thing that I really focused on when I went to fellowship, which is subspecialized training, for 1 year, and I went to the University of Rochester in upstate New York, is focusing on hip preservation, and it's arthroscopic hip preservation. So again, using minimally invasive techniques in order to help preserve the hip joint. So this is most beneficial for people that don't have significant arthritis in the hip, because unfortunately at this point we don't really have a great way of replacing cartilage in the hip joint at this point. And so this is for somebody that has potentially a labral tear, issues with the soft tissues within the hip joint that we're able to repair arthroscopically. And a lot of people come to me with pain in the groin, would be most common, especially with activity such as trying to walk up and down stairs, even just walking on flat surfaces. Sometimes people will have significant groin pain. People will even complain of groin pain when they're sitting for prolonged periods of time.
So and so sorry to interrupt, but
No, you're good.
they can feel it. It may be related to the hip, but the pain is actually resonating from a different area that people might not know it's their actual hip.
So typical ball and socket joint pain in the hip actually occurs, and you will feel it most commonly in your groin. Now, some people will have presentation with lateral hip pain or posterior hip pain, but most commonly those are coming from different areas, potentially the back, the SI joints, potential problems with what are called the bursa on the outside of the hip. You can get a bursitis, things like that.
Okay.
So great question there. But with hip arthroscopy, it's one of these procedures that not as many people do because of the complexity of the procedure. The ball and socket joint of the hip is very complex, and it's a very deep joint compared to like the shoulder and the knee. And so for a full year, I trained underneath Brian Giordano, who is a world-renowned orthopedic surgeon in the realm of hip surgery. He did close to 400 or 500 hip arthroscopies a year. So during my time in Rochester, I was able to observe and help in several hundred hip scopes while I was there, and it was a great learning experience to see how some of these guys that are treating just so many people are doing things. So it really increased my ability to help offer significant help to the population here, which I'm excited about. So then we get into total hip replacements, and somebody with a total hip replacement will still have, or that needs a total hip replacement, will still have groin pain. Arthritis in the hip still creates a lot of groin pain, but they may notice a lot more kind of ratcheting and catching in the joint compared to somebody that just has a labral tear. Okay. So again, a lot of these things have to have further imaging, such as X-ray, MRIs, to further diagnose what's most appropriate. But a total hip replacement is a game changer for people that have been suffering with arthritis in the hips, where we're able to go in and replace the joint surfaces so that they can get back to those activities that they've been missing for so long.
Okay. So we've talked about the shoulder, and you've talked about the shoulder and hip. Mm-hmm. What do you specialize in with knee surgeries and procedures?
Yeah, so with knees, again, I do arthroscopic knee care. So that entails anything from like a meniscus tear to potential cartilage injury. In the right situations, if someone has an isolated cartilaginous lesion, meaning at the end of the bone where the cartilage is, if there's an isolated spot in the bone that for some reason or another they had an injury that caused that cartilage to be worn out in just a specific area, we have procedures that we're able to go in and help replace cartilage. Like I said, in the hip, we're not quite there yet, but in the knee, we're able to do some of these procedures to help restore that cartilage for people without the need of necessarily going in and doing a partial or a total knee replacement. So like I said, meniscus injuries, cartilaginous injuries, also ACL injuries. I see a lot of ACL injuries from, anyone from athletes that are playing sports where there's a lot of, twisting, turning type injuries, to, people out skiing that have an injury where they fall and twist their knee and injure that ACL. So ACL surgery is definitely something that I specialize in, and that we're able to get great results with people getting back to their activities. And then, as people start to have more and more arthritis, sometimes we'll see people come into the office that are, young in their late 40s, early 50s. And on X-ray, we see that one side of their joint has significant wear when the other side's well preserved. And so this patient would be a potential candidate for what we call a partial knee replacement. Okay. So instead of going in and resurfacing the whole entire joint, we're able to isolate that one compartment and be able to replace that so that the patient can go on to have, pain-free activities. And the nice thing about the partial is the recovery is very quick, and patients have commented on how quick they've been able to get back doing things that they enjoy. And one thing that's been able to facilitate me wanting to do more of these partial replacements is the use of the Mako robotics. So I'll be quite honest, when I got out of my training, I didn't know if partial knee replacements were going to be something that I would offer to the public. And it was purely because a lot of my training, the way that we did the partial knee replacements, was with different types of jigs and things that help us align the component in the appropriate manner. Well, as you can imagine, if we're just using jigs, there's definitely some room for error in there. And I was never quite satisfied with the reproducibility of being able to put those joints in. But with Mako Robotics, this is getting a preoperative CT scan prior, which is then uploaded into a computer software system that's associated with this Mako robot. We're able to put this information to use so that when we put that prosthesis into the knee, we're able to put it in exactly how I feel that it needs to be there to give that patient the best longevity and reproducibility with that prosthesis. And
So I was gonna just sorry to interrupt,
You're
but
good.
I wanted you mentioned the Mako robotic system. Could you talk about some of the benefits of that? I feel like my understanding is that there would be a lot less pain after recovery. The procedures are typically a lot more minimally invasive, so that means smaller incisions than what the procedures used to look like.
Sure.
What do you talk to your patients about when you talk about the Mako?
Yeah, so I think that there's a little bit of misnomer when we talk about minimally invasive. It doesn't just mean smaller incisions. And I'll tell you, sometimes with the Mako, the incisions are the same size as what they were previously. But what's minimally invasive about using Mako robotics is when we have that information on knowing not only where the bone is, where all the soft tissue is, where the the neurovascular structures, that instrument, that arm that helps me make my cuts, actually keeps me from getting into those important structures. And so previously when we did total knees or partial knees, we use what are called retractors to protect soft tissue and to protect the neurovascular structures. But there's a chance that with that saw blade that's moving, that some of the soft tissue surrounding that area could potentially get damaged. Now I still use retractors and I still protect everything. But with the use of the Mako, it knows exactly where the border of the bone is, exactly where my cut is going to be made. And so I would say that there is less soft tissue damage. And that way, I think I have seen patients have, I don't, it's still a painful procedure. You've got to understand that we're replacing the joint, so there still is some pain involved. But I would say that patients do recover a little bit quicker as far as pain goes because of having that less invasive nature to the surrounding soft tissues.
I would imagine. So I'm imagining that it's kind of like you have an X-ray of the area that you're going to be operating on. So it's almost like a 3D scan that
Exactly.
you can work from while you're working with more precision using the Mako. I know that a lot of patients, they come to you because they're in some sort of pain.
Sure.
And and I know that you have a lot of procedures. There's a lot of things that you like to try to do. I don't know if the triage is the right word, but there are a lot of things that you like to try to do, maybe like cortisone inject, or maybe there are a lot of things you like to do so that when people come to you, it's not necessarily you're going to say you have to go into surgery right away. There are a lot of other things that you try to do before a patient gets to surgery. Is that right?
Absolutely.
Is that accurate?
Yeah, absolutely. I think one of the things that I pride myself on is that I'm a very conservative surgeon. And so I think if anybody's ever going to get mad at me, it's because I'm going to try to encourage them to try options other than just jumping straight to surgery. Now, granted, there are times when I see a patient and there's no doubt that surgery is the only option, but for the majority of my patients, we definitely try, like you said, injections of all different sorts. There's cortisone injections. There's, for the knees, there's what we call a viscosupplementation injection that helps improve the health of the joint. There's biologic types injections, which are, maybe you've heard of PRP or platelet-rich plasma. There's stem cell injections. So we go through all of these different options with the patients, and we can't forget physical therapy. In my training, I'm a DO, which is a doctor of osteopathy. And, the difference between a DO and an MD is an allopathic doctor, a DO is an osteopathic physician. And really the only difference is some of the thought process behind it, some of the philosophy. And the philosophy with osteopathic physicians is that the body has its own innate potential to heal. And so we try to, capitalize on that, and we try to help get patients into physical therapy, get them doing exercises, get them doing, if it's appropriate for bracing, things like that we would try these things before just jumping straight to surgery.
That's fantastic. One of the other things I think that people have the perception with orthopedic surgeons is that they have to be an athlete or they have to play sports in order to see an orthopedic surgeon. What kinds of patients do you actually see? Who comes to you? What age ranges? And what are some of the things that people are maybe experiencing? Why they would want to schedule an appointment or consultation with you?
Yeah. So, in all honesty, I see patients of all ages. I've seen, infant to, people in their 90s. remedies. And so really patients of all ages, if they have joint pain, if they have pain of any sort around the bones, things like that, we're able to help take care of them. And like I said, if you've been suffering from a pain in the hips, a pain in the knees, a pain in the elbows, shoulders, and this has been ongoing, and you've tried, natural home remedies such as, anti-inflammatories, and things like that, then I would definitely say that any of these people would qualify. And another great resource are your primary care physicians. Your primary care physicians are well educated and know which patients would potentially benefit from seeing an orthopedic surgeon. So if you have question and you want to look into that further, you could always reach out to your primary care physician, who I'm sure would be happy to assist you in getting to an orthopedic surgeon to be evaluated.
Okay, that's fantastic. I think, Dr. Pearson, you've done a really great job at explaining each area of the body that you focus on and help people with their pain and what you can do for them. Part of this this Be Informed webinar is actually to answer some questions that people have been asking on Facebook,
Okay.
and I've been getting some of those that have been coming through, and I thought maybe we could start answering some of those questions, and then if there are other things that you'd like to elaborate on, then
Absolutely.
we can go from there. Does that sound okay
Yeah,
for right
perfect.
now? Okay. So the first question that we have is from a 58-year-old female that has increased pain in her hip and lower back for the last 6 months, and it's getting harder to exercise.
Okay.
Her first question is, she wonders if is exercise making it making it worse?
Yeah, so that's a tough question. Exercise, joints love to move. Okay, so if you're exercising and you are having increased pain, then we need to take a step back and look at what exactly you're doing. It could be the types of exercises you're doing are exacerbating her pain. With hip pain especially, it's important for patients to stay away from deep squats. If you're experiencing groin pain and you're going to hit the gym, I would avoid deep, heavy squats. And what I mean by that is, if you're getting down to a 90-degree position, that's probably a little bit too low for where you should be going. I would encourage my patients with hip pain to, if they're wanting to try to continue doing squats, lunges, things like that, I call them baby squats, baby lunges, where they would do like a 30-degree squat. And I would try altering the way that I'm exercising to see, is it the exercises that are maybe just in and of themselves making things worse. And so I would say, for this lady, I would say that maybe take a look at what types of exercises. I think getting on a treadmill and doing some walking is fine. I would say doing an elliptical would be a good exercise to try, and then also getting on a bike and doing some spinning and trying to focus more on that cardiovascular exercise at this point rather than some of those other exercises. A lot of the core, deep, heavy exercises that we're doing could be exacerbating your symptoms. So I know it's not exactly probably the answer you're looking for, but yes, there is a chance that if we're doing, a lot of the exercises that people are wanting to do nowadays, you see all this, the Pilates, the Zumba, the P90X, a lot of these exercises can be great exercises if we have the appropriate base and fitness behind us. But if we're, just getting into exercising and don't necessarily have that base, then I would say that we need to build up to those exercises before we hit those really tough, exercises that they could be doing.
So to expand on that a little bit, if someone is experiencing pain and they do have an exercise regimen, is that something that they could call you and schedule just a consultation with you for like 30 or 45 minutes to be able to actually talk to you about their exercise plan and have you help them, give them a more customized plan that could help?
Yeah, so absolutely. I'd love to see patients if they're having, joint pain and they have questions on whether the things that they are doing could be exacerbating that. Absolutely. We'd love to set that appointment up. And all of my appointments, I try to take time we have athletic trainers as well that that accompany me in a lot of my visits, and they're a huge resource, and I use them a lot because a lot of what they can do is help the patient after we've discussed all the things that they should and shouldn't be doing, is go through a specific exercise plan and make sure that they understand all the exercises specifically.
Okay. So the same woman actually says, and you probably get this a lot. She says ibuprofen helps with the pain, but she tries not to take it. What do you recommend when someone is in that situation?
Yeah, so I guess it depends on how long she's been trying the ibuprofen. If this is something that she's been dealing with for a year or more, it's probably time that we get that taken care of and looked at. Ibuprofen's a great anti-inflammatory, but there are consequences to everything that we put in our body. And so over time, if we're taking ibuprofen, it does get excreted through the kidneys, and so you could potentially injure your kidneys if we take too much of this for a prolonged period of time. So in that case, I think it would be important to get evaluated and have us look further into this.
Okay, and this is something that you elaborated on a little bit earlier. But so if she were to come in to see you, she was asking, how do you determine when surgery would be necessary for something like this, or understanding if it's just arthritis? What would you do to be able to make that diagnosis?
Yeah, so when she came in, I would have her get some x-rays. So x-rays are great two-dimensional images that, again, they tell us a lot about the joint. With the process of arthritis, you get lots of different things that occur. You get joint space narrowing because of, like what I was telling you earlier, that cartilage starts to wear away. And so we would see potential joint space narrowing within that joint. The other thing that can occur in a normal arthritic process is cystic formation. So we can actually see in the x-ray cysts starting to form within the bone surrounding that joint. And then another thing is called osteophytes or bone spurs. So as the cartilage starts to wear away, that joint surrounding it starts to feel more pressure than what it did before. It had that nice cushion in there. And because of that, the body is stimulated to grow these bony osteophytes or bony spurs. And so we start to see these different things that cue us into the fact that, this patient may be suffering from an arthritic process. And if it's advanced, then that's when we would start talking about, other things that we could do to try to help prolong things so that they don't necessarily have to go straight to surgery, such as injections, physical therapy, and things like that. And if it gets to the point where those things are not creating a good quality of life for that patient, then we would proceed and talk about different surgical options at that point.
Okay, that's great. So moving from the hips, we have a question from a viewer who is asking what your thoughts are on having both knees replaced at the same time.
So this is going to be something that you'll probably get a different answer from each orthopedic surgeon that you talk to. In my opinion, I think that that's not something that I offer to my patients. And I know a lot of patients are like, well, but I want to get it all just taken care of right then and there. But if you look into the literature, there's significantly increased risks that come along with doing both knees at the same time. Your risk of infection goes up, your risk of blood clots go up. And, I think, quite frankly, patients do really well when we stage these procedures and we give them a 3-month time period in between the procedure to heal, to be able to go on to the other knee. So in my personal opinion, that's something that I avoid. I don't want to see the complications arise from trying to be too eager and do them both at the same time.
Okay, and so what I heard you say, to reiterate, is you would recommend having one knee replaced, and then they could potentially have the second knee replaced about 3 months later.
That's correct.
That's about it would be an adequate time for recovery.
Yeah.
Okay. Yeah. So we have another question from a viewer. When walking upstairs, my left knee will not support my weight without a lot of pain. What would you recommend in that situation?
Yeah, so there can be a lot of reasons that you feel like your knee is buckling or giving out on you. It could be because you have arthritis in that knee. It could be, if you are suffering from a meniscus tear. So let's back up a little bit. A meniscus tear is a cartilaginous disc that's in the knee, and you have 2 of them, and they're C-shaped discs. And if you had like an injury where you fell, twisted the knee, you could have torn one of those discs. And when the body senses pain in the knee, there's a arc that happens, or a feedback mechanism that happens to the quadriceps. And your quadriceps tendon or muscles can be inhibited by having pain in the knee. And it's basically the body's response to trying to stop you from walking, or stop you from hurting that knee further. And so that response that you're getting where you're feeling like your knee is giving out, it could be because you have a meniscus tear. And along with meniscus tears, a lot of people will feel like they have a catching or a clicking or a locking sensation in the knee. And so if you're suffering from those, it's very likely that you could have a meniscus tear. It's also a possibility that you could have some sort of other injury inside the knee joint that could also be causing this. So in that case, I would definitely suggest, if you're wanting to try some home remedies, you could try doing some exercises where you strengthen your quad muscles, doing some straight leg raises, doing some leg extension exercises. These could be things that help strengthen that quad. And if it's not improving after about a 4-week period of time, then I would definitely call, and we can definitely take a look at that for you.
How many times a week would you recommend doing those types of exercises for your knee, which people can research online? They
Sure.
can find different exercises. How often during the week would you recommend doing those?
So I would say it's important to be diligent at doing those pretty much every day. I would say you can take 2 days off a week, and whatever days are best for you to take off during the week, I would say use those. But then at least 5 times a week, I would be doing your exercises.
And then for about 4 weeks, and if they don't really notice anything strengthening or the pain diminishing, then that's
Absolutely.
when they would probably want to call you, because
Yep.
you don't want them to injure. You wouldn't want them to injure themselves.
Exactly.
The other thing, so you've talked about the meniscus. Can you elaborate a little bit on an ACL? We hear that acronym,
Sure.
but I don't even really know how I would define or describe it, what an ACL is.
Yeah, so when you think about the knee, there's 4 different ligaments that really support the knee. And so we call those the lateral collateral ligament, the medial collateral ligament, and then those are on the outside of the knee. And then the cruciate ligaments, which ACL stands for anterior cruciate ligament, are on the inside of the knee. And what they do is they help to support the knee from having the bones shift apart, basically. And so what you end up seeing is somebody with an anterior cruciate ligament or an ACL injury typically has a twisting injury with the knee in a bent position with force upon the knee that causes that to rupture. And so that's what the anterior cruciate ligament is. And it's a ligament that's very important if you plan on doing anything that requires any pivoting, shifting, turning, twisting. If you rupture your ACL and all you're going to do is walk in straight lines for the rest of your life, then you probably don't need an ACL. But if you plan on doing anything of any higher level activity, then looking into an ACL reconstruction would be important. And you can do a lot of research. There's a lot of different ways that ACLs can be reconstructed. There's different grafts that we would discuss, such as a bone patellar tendon bone graft. There's a hamstring graft. And these are all things that I would detail out in our conversation if that's something that arose.
Okay, fantastic. We have another question here. If your knees are bone on bone, do you have to have a total knee replacement?
Yeah, so that's a good question. So like I talked about earlier, in the case where you have an isolated cartilaginous injury, those scenarios, we do have the option to potentially replace cartilage without doing an arthroplasty or a total replacement. But in the case of somebody that has truly bone-on-bone arthritis, where they're all their cartilage has worn away to the point where we see on x-ray that they have no more space in there. Then the next surgical option, now granted, just because you have bone-on-bone arthritis doesn't mean you necessarily have to have surgery, right? It depends on your quality of life and what you're able to do. I've definitely seen patients that still get some relief from injections and different things that we're able to do to the point where they don't want to have surgery, and we support them in doing that. But at the point where it's affecting affecting your quality of life to a point where you are unhappy and unable to do the things that you enjoy doing, that's the point where I would say yes, definitely. The next step would be a joint replacement.
Okay, and this is another question. It's actually very similar, but I at least like to ask it. So we're acknowledging everyone who's been participating
Sure.
in this Be Informed webinar. That way, and if you can maybe you can answer it in maybe a little bit different than what we've already talked about. What is best when it's bone-on-bone shots, but it doesn't last long enough? Is it hard to get up or sleep because they hurt, or it's difficult because they hurt? There is a fear because it feels like my knees lock up on me.
Yeah.
So I don't know. I've said that. I don't know if there's another way.
Yeah, so the patient, if they've had X-rays and that they know that they're bone on bone, again, it goes back to really, how much benefit you're getting from an injection. Cortisone injections, or these anti-inflammatory injections that we do, we really recommend that you only get 3 to 4 of them a year. So that's only every 3 to 4 months. And if a patient, I see this where patients will get an injection and get 4 months of relief, and then they get another injection and get another 4 months, but maybe a year down the road, they're only getting a couple of weeks of relief. And I think at that point is when they start saying, okay, if I'm not getting the benefit and I have to suffer for 3 more months just to get 2 weeks of relief, then at that point I would say that the patient should be looking at potentially getting a joint replacement. And they mentioned in there that their concern is that they're feeling, you said some grinding, right?
Yeah, bone on bone.
Yep. And so definitely somebody that's suffering from bone-on-bone arthritis is going to feel kind of a ratcheting type sensation because they don't have that smooth cushion anymore to glide on. And so that's most likely what they're experiencing, is that arthritic change that's causing their joint to not feel smooth and having that free gliding sensation.
Yeah, and I know when you talk about having a total knee replacement or a total hip replacement, I would imagine that could be really scary for a lot of people, because that would be why they're apprehensive about wanting to come and see you, because they imagine they have this fear about what they think what it's going to be like when they have the surgery and there's the pain. But I have a lot of friends and family who have had those kinds of replacements. And they're life-changing. Can you talk about how people's lives have changed after they've had these different surgeries or procedures?
Yeah, absolutely. I think that's a very valid point. It is scary to go in and to think that you're going to have a joint replacement. And I'll start with this. I think that sometimes people get a misunderstanding of what a joint replacement is. For the knee, I've had patients say, "Are you going to lop off the bone here and lop off the bone here and put a huge chunk of metal in there?" And truly, that's not what we're doing. We're truly resurfacing the end of the joint, and being as minimally invasive as possible. But aside from the surgery, every patient that comes into my office, we have a detailed conversation of what exactly is going to occur during the procedure, what exactly we're doing. We try to answer every question that patient may have. But then the other great resource that we have is, before each joint replacement, we actually have a joint replacement class that the patients participate in, and it's where we have somebody that comes in and teaches the patients what exactly that they should expect after a joint replacement, and things to prepare, not only in the house, but things to make that they wouldn't necessarily be expecting. They make sure that the patients have the appropriate ambulatory aids after surgery, make sure that everything is set up so that it can be kind of a seamless a seamless experience for the patient, from the time that they are in the office seeing me to the time that they have surgery, go home and start their rehab. So definitely we have support for these patients so that they can feel comfortable and feel like that they're ready for what's ahead.
Okay, great. Let me. I have a couple more questions that have been coming in here. Let me ask you before my phone locks up again.
You're fine.
So I hurt the person. Chelsea's asking, I hurt my knee last fall through an accident. I didn't exercise all winter because of it, but I'm really wanting to get back out and be active again. What can I do to ensure I don't re-injure my knee? Sure, a lot of people are in that situation.
Yeah, absolutely. And it's unfortunate. It is, being here in Southeast Idaho, we definitely have that time of the year where we can't get out and do much exercise. But I think that getting back to an exercise program, I would definitely, not encourage anybody to start off with the exercise program that you may have had prior to your injury. I would start off small. I would start off, doing some walking on a treadmill, doing some light knee range of motion exercises, and I would see how you're doing with all of that. If these exercises such as elliptical, spinning on a bike without any resistance are causing pain, then it would probably be a good idea to get in and be seen sooner than later. But if you can continue to advance your exercises and strengthen, the muscles in the lower extremities, and you really want to focus on balancing the anterior muscles and the posterior muscles, meaning your quads and your hamstrings, your gastrocs, and everything surrounding the hips, so that you protect yourself.
Okay. Another question that we have from a viewer, Mike, asked, his mother is looking at having her knee replaced. Should she be considering the Mako over traditional surgery? How would you make that decision? Do you to use the Mako or traditional, or do you even have to make that decision anymore?
Yeah, so at this point, because we have the Mako robotics available to us, I use that for all of my total hips and all of my total knees. Now, for my total shoulders, we still don't have that technology available for the total shoulders, but I'm told that hopefully it's within the next several years that we'll be having that. So I use Mako robotics for all of my total hips and all of my total knees and partial knees as well. And like I explained earlier, this traditional way has been very successful for a number of years. Really with Mako robotics, as we explained earlier, you get that benefit of the minimally invasive in the sense that it helps protect the surrounding soft tissues, but more so than that, because of having that 3D or three-dimensional scan of the patient's anatomy, we're able to put the prosthesis in with more confidence and more reproducibility and get more precision when we put those prostheses in, with the hopes that doing so will help increase the longevity of that prosthesis for that individual, because the chance of needing a revision goes up if the prosthesis isn't put in appropriate alignment.
Okay, that's understandable. I think you talked about this a little bit earlier, but in general, I imagine it would vary depending on the type of surgery that someone has to have. But someone is just asking, what would the recovery time be for a hip replacement?
Yeah, so after a hip replacement, believe it or not, we're able to get the patient up and walk them the same day with physical therapy.
Okay.
So they're using a walker, and everyone progresses at a different rate. It depends on their level of health and fitness prior to the surgery. But the goal is to get them back ambulating without any ambulatory aids. And what I mean by that are walkers, canes, things like that. So definitely for the first 2 to 4 weeks, you're looking at using a walker during that time period, and then we transition you to a cane. The first week is probably the most difficult time after a joint replacement, with pain and everything like that. But it just progressively, week by week, gets better and better. I would say most patients with a total hip replacement at 6 weeks are able to go to the grocery store. They're able to get out and about and do things. Now, they're not running marathons yet at that point. Yeah. But they're able to have a better quality of life at about that 6-week mark. We supplement that first 6 weeks with physical therapy so that we're working on strengthening those hip abductors, the external rotators, and all the muscles surrounding the hip so that they can regain that strength and regain their mobility.
Okay, and we have another question that's just come in. This probably will be a little bit more I imagine will be a little bit more difficult for you to answer, but at least maybe you can provide some general answers to it. What are the symptoms that may require knee surgery that when people see you?
Yeah, so that is more difficult just because it's so general.
Yeah.
Nonetheless, anybody that's experiencing locking or catching in the knee, that's definitely something that I would get checked out and be seen for. Any pain that has been going on for longer than 6 weeks, I would come and get checked out for as well.
Okay. And then the same thing for what about a shoulder replacement? What kind of symptoms would you see for that when one would actually need to be recommended?
Yeah, so typically with arthritis of the shoulder and needing a shoulder replacement, you're going to have decreased range of motion in that shoulder. They're going to notice that, before they're able to lift their arm clear to the ceiling, pain-free, and now they feel a ratcheting sensation as they're lifting that arm to the ceiling and maybe can't even get it all the way up over their head anymore. So that's more of a symptom that you would notice with arthritis in the shoulder.
Okay, and then we have another question that's just come in here from Janice.
Okay.
Do you perform surgeries anywhere besides Bingham Memorial Hospital?
So currently, I perform them all at Bingham Memorial Hospital. In the future, there may be options for me performing them here in Idaho Falls. But as currently, I'm only performing the surgeries at Bingham Memorial Hospital.
Okay, and just to clarify for all of our viewers watching today, Bingham Memorial, for those of you who may not know, Bingham Healthcare. Actually, Bingham Memorial Hospital is a proud affiliate of Bingham Healthcare, and Bingham Memorial Hospital is located in Blackfoot, Idaho. But just to mention that Dr. Pearson actually sees patients in Blackfoot, and he also sees patients here in Idaho Falls. And at the end of our Be Informed webinar, I'll actually be sure to share those addresses with you. And then in the meantime as well, you can always just go to binghammemorial.org, www.binghammemorial.org, and all the information about Dr. Pearson is on there as well. So you can find that, and you can find a lot of information about the different surgeries that are performed by Dr. Pearson and more details about those if you're interested. The other thing that someone is asking is they are saying, I'm 35 years old with arthritic knees. Should I wait to get a knee replacement, or what options are there for me? That kind of ties into a little bit about what you talked about earlier.
Yeah.
Maybe why don't you just reiterate some of the things that you would do?
Yeah, so, definitely at 35 years old, I wouldn't advocate getting a knee replacement at that point. We would want to try to exhaust every other option possible. And I know that's a hard concept sometimes for patients to understand that, well, why not just get me out of pain right now? I'm in pain. I know a knee replacement would fix that. But there's obviously repercussions and risks that we take with everything that we do. And somebody that gets a knee replacement at age 35 is going to wear out that joint quicker than somebody that's in their 60s or 70s that gets a knee replacement and will need what we call revision replacement. And then when we start getting into revision replacements, we start increasing the amount of risks that are taken with procedures, the amount of bone loss that occurs, and things like that. So I would definitely, if you're 35 and you're suffering from knee pain and have some arthritis, I would definitely come in and let us evaluate and see if there's one of these more minimally invasive procedures that we could do, if there's something that we could replace cartilaginously, and at worst case scenario, hopefully we would be able to offer maybe a partial knee replacement in that case for somebody that that has pretty global arthritis on that one side of the knee, but the other side is well preserved. We could still potentially offer a partial knee replacement, and that would be potentially better, I think, in my opinion, than going straight to a total knee.
Okay, and so just to clarify, and I'm probably not going to say this the right way, but I just wanted you to be able to define cardiologically.
Like cartilaginous?
Cartilaginous.
Yes.
I apologize.
You're okay.
How would you define what that is?
So cartilage is the substance on the end of the bone. So when I say cartilaginous injury, I'm just referring to that cartilage injury or the arthritic injury at the end of the bone.
Okay. Well, it looks like we're actually winding down with the questions that we have. So if there's anybody out there that wants to submit any more questions, please let us know before our webinar ends. One of the final questions that I have is from a viewer. They've asked, are there any activities, and maybe you could elaborate on this for shoulder, hip, and knee. Mm-hmm. Are there any activities that someone won't be able to perform after having a joint replacement? But I guess that's situational as well.
Yeah, so with a partial knee replacement, there's definitely going to be less restriction. It's important that the patient come into this and have a good understanding and a good knowledge of what they're getting themselves into. Because, I mean, we've got to understand that a total knee or a total hip or a total shoulder is not going to be the same joint that they had when they were 20 years of age. And so, unfortunately, a total hip replacement, a total knee replacement isn't necessarily meant for somebody that to go and avidly run on. Now, will they be able to jog back and forth and do some, fun activities with grandkids and things like this? Absolutely. But to be like a competitive runner, somebody that's going to be doing that type of strenuous activity might be a little bit outside of what is capable. But to be able to get back to hiking and enjoying the outdoors with things like that, I definitely think that they'd be able to get back to doing those things. But that would be an awesome conversation that we could have in the office and go over specifically what your concerns are, what your hopes and aspirations are for after a total joint, and just make sure that your expectations and my expectations align. And then I think once we have that, understanding of what each other's trying to accomplish here, that's when we have the best results.
So that would be great. You would work with your patients to be able to kind of come up with a customized exercise plan and say, hey, these are things that you can focus on and that you might even enjoy more than the other activities that they were doing before, and then just kind of help to guide them through. And I imagine you would always be available to answer any questions that people would have after their surgeries. And,
yeah, absolutely.
Okay.
Yep.
We're nearing the end. I was just wondering if there's anything, I know we've had a really great conversation today. I was just wondering if there was anything else that you wanted to mention that, you see with patients or that you feel like you maybe haven't had a chance to talk about or elaborate on.
No, I think we've hit a lot of good subjects. We've talked a lot about the shoulder, hip, and knee. I don't know if I have anything specific. I just hope people, during this uncertain time that we're having, it's we definitely are open and available to see patients and see their injuries. We're taking appropriate precautions, wearing masks in the clinics, things like that, to make sure that we're staying in alignment with the CDC recommendations and everything, and be able to have those conversations. I know a lot of people are fearful right now due to the COVID situation, and being able to get into the hospitals, have surgeries, things like that, and just so people are aware, we are open and doing elective procedures, but we're making sure that we're screening patients appropriately so that we're not putting people at undue risk going into the hospital.
Yeah, that's a really, really great point that you bring up. I know that in all of our waiting rooms at Bingham Memorial Hospital and all of our clinics throughout Eastern Idaho, they have, all of the waiting rooms are being customized now. So there's social distancing that's, in place. Masking is required in the office. Temperatures are being taken. And I know that you have been seeing patients and are continuing to see patients in office, but I also understand that you're offering telehealth visits as well.
Yeah.
How I know the number will be, his phone numbers will be showing up on the screen that you can call. How are the telehealth visits so people can talk to you online or over the phone, maybe as a consultation or a preliminary visit? How have those been going for you?
Yeah, so I'll say that the telehealth has been an amazing tool. It's been especially helpful for patients that have had surgery that maybe need a follow-up exam or a follow-up visit, I should say, but don't necessarily want to take the risk to come into the office. And I think that they've been very beneficial. Now, having a telehealth visit for an initial evaluation can be very difficult because a lot of what I do is hands-on testing and things to diagnose what's going on. So it is very much limiting in that regards in orthopedics, but it has been very beneficial for follow-ups and things like that. So if someone's had surgery or has had some sort of treatment, maybe gone to physical therapy, we can follow up over telehealth so that they don't have to come into the office.
Okay. And I even imagine with a telehealth visit, it would be easy for someone, if they have questions or just want to kind of understand what next steps they should be taking,
Absolutely.
would be an opportunity for them to schedule and call. Okay. Well, Dr. Pearson, I really appreciate your time and being with us today. I know that a lot of viewers have been really interested in providing a lot of positive feedback about, the answers, the questions that you've been able to answer.
Oh, good.
So I really appreciate you joining us. I do want to let everyone know that, again, that Dr. Pearson, Nicholas Pearson, sees patients at Bingham Memorial in Blackfoot, and that's at 98 Poplar Street. And I know that this phone number is on the screen, but if you're interested in scheduling an appointment with Dr. Pearson in Blackfoot, you can call 208 785 2220. Again, you can call 208 785 2220. And then, in addition, Dr. Pearson also sees patients throughout the week in Idaho Falls. And that's at our comprehensive cares clinic in Idaho Falls, right near the intersection of Sunnyside and Hitt Road. It's a building that's just before that intersection, and that's at 3302 Valencia Drive. And the phone number for his office, if you are interested in scheduling an appointment in Idaho Falls, is 208 524 9400. Again, that's 208 524 9400. And then, to re-mention it, the website for more information about Dr. Pearson or any of the specialties that Bingham Healthcare providers provide is at www.binghammemorial.org. Again, www.binghammemorial.org for additional information. Again, Dr. Pearson, thank you so much for joining us today. And in addition, I'd really like to thank everyone who's been watching the first in a series of our Bingham Be Informed webinar series. We will be hosting these live seminars with Bingham doctors regularly. So please be sure to keep an eye out on your Facebook news feeds or at Bingham Healthcare, Bingham Healthcare's Facebook page or Bingham Memorial Hospital's Facebook page. More information about our upcoming webinar series will be available then. So again, thank you for everyone being with us today. Please stay happy, healthy, and safe, and have a great day.
Thanks for having me.
Thank you.